Assalamu alaikum, dear student. It is my privilege to present this lecture today. I am Dr. Mostafa Shalaby, lecturer of colorectal surgery, Mansoura University Main Hospital. These are our objectives. We'll start with definition of hemorrhoids. Hemorrhoids are a normal part of the anal canal, submucosa formed of series of vascular cushions. This vascular cushion composed of blood vessels, smooth muscle, and elastic connective tissue. Arterial blood supply is mainly from branches of the superior hemorrhoidal artery. Venous outflow represents a connection between the portal and systemic circulation, but important to know, rectal varices is a different entity from hemorrhoids. These vascular cushions are thought to be involved in continence mechanism. This is the normal anatomy, and this is the hemorrhoidal plexus above the dentate line. This is the dentate line. This is internal hemorrhoidal plexus. This is external hemorrhoidal plexus, and this is the muscle fiber, which is the reads muscle fiber, originating from conjoint longitudinal muscle. And this is how hemorrhoid contribute in the continence mechanism. In case of sudden increase of the intra-abdominal pressure, decrease in the sphincter tone, in this condition, there will be engorgement of the hemorrhoid, and this will contribute to the continence mechanism by a percent of 15% of continence mechanism. It is multifactorial, and there are certain controversies regarding different theory available. Vascular hyperplasia theory, now it is obsolete, based on the histological study of hemorrhoidectomy specimen, showed no sign of vascular hyperplasia. Varicose vein theory, it is also obsolete. It assumes there are a pathological dilatation of the venous plexus. However, this dilatation confirmed to be a normal anatomy. The most accepted now is the anal sliding lining theory. Increase in the intra-abdominal pressure result in engorgement and disruption of the submucosal smooth muscle fiber and subsequent prolapse. Other factors, including in the pathogenesis of hemorrhoid, may be hereditary, erect position, those standing for a long time, like teacher, absence of valves in the hemorrhoidal plexus and the draining veins, and obstruction of the venous return from raised intra-abdominal pressure. Secondary to inflammatory bowel disease or deterioration of the supporting tissue. Classification: hemorrhoids classified as internal and external or mixed. Those above the dentate line is internal hemorrhoidal plexus, and those below the dentate line are external hemorrhoidal plexus. In addition, there is a classification system of internal hemorrhoidal plexus based on the degree of clinical prolapse. These classifications are important in the treatment of hemorrhoids. And this is the Gallagher grading of internal hemorrhoid. And starting with grade 1, there is no prolapse. And this is grade 2, there is a prolapse during the defecation. However, this prolapse returns spontaneously after the defecation. Grade 2, there is a prolapse, but this prolapse occurs during the defecation and should be reduced into the anal canal by digital manipulation of the patient. And this is a chronic prolapse, and it not return to the anal canal anyway. Clinical presentation: common symptoms including bleeding, pain, and prolapse. These are the most common symptoms. However, patient may describe there is itching sensation. There is a variation in the severity based on type of hemorrhoid. Is it internal, external, or mixed? In case of internal hemorrhoid, the main symptoms: painless rectal bleeding and prolapse. In case of external hemorrhoid, it is rectal bleeding and pain. Sometimes it is difficult to differentiate between external hemorrhoid and internal hemorrhoid, especially in case if there is engorgement of the external hemorrhoids. Hemorrhoidal bleeding. It is similar in both internal and external hemorrhoids. It is bright red blood in stool, dripping in toilet or on webbing after defecation. It is variable in frequency, and it is very unusual, this bleeding to lead to anemia. So if we have a patient suggested to have a hemorrhoid and we find this patient has anemia, we should investigate the cause of the anemia. B. Internal hemorrhoid is rarely painful. However, in case of external hemorrhoid, it is likely to be painful. So if we have a patient with internal hemorrhoid and this patient have pain, we should exclude other pathology or complication. Prolapse, more common internal hemorrhoid than external hemorrhoid, and in certain situations may be there is a prolapse of the intraanal portion of the external hemorrhoid. Physical examination. Inspection with gentle traction is very important. Digital rectal examination to assess for masses, pain, sphincter tone, and endoscope. It is important to complement the digital examination. Digital rectal examination with endoscopy. In certain situations, we can ask for colonoscopy in those patients who have a risk of malignancy, to rule out malignancy, like an elder patient with bleed, weight loss, anemia, or a change in bowel habits. Thrombosed external hemorrhoid. This is a common complication of external hemorrhoid due to intracapillary thrombosis. Most patients give no history of straining, or they may be assumed that they don't have any history of hemorrhoidal disease. It is associated with sudden onset of anal mass, burning pain, and the pain peak within 48 hours. It is usually a self-limited condition. Maybe the overlying skin becomes necrotic, causing bleeding, discharge, or infection. Maybe in certain situations, if there is a large thrombus, can result in skin take. And this picture of thrombosed external hemorrhoid, and this is the external hemorrhoid, and there is a thrombus inside. Strangulated internal hemorrhoid arises from irreducible prolapse grade 3 or 4 hemorrhoids. Patient history reveals long-standing hemorrhoidal prolapse on straining, and the condition usually associated with severe pain and urinary retention. If untreated, the edema may progress to ulceration and necrosis. And this is a picture of strangulated internal hemorrhoids. And this is a gangrene of the hemorrhoids. Treatment, line of treatment, medical treatment, office-based procedures, surgery. Factor affecting the choice of the treatment, classification, grades, and the symptom. Medical treatment, including dietary modifications, and this dietary modification is similar to those of treatment in inner fissure. It consists of high fiber diet accompanied by adequate fluid intake to avoid bloating. The target to increase the fiber intake, 38 grams for men, 25 for women. Increase the fluid intake, 2 liters of plain water per day. The desired outcome, soft, will form a stool that can be expelled with minimal effort. We can prescribe laxative in those patients who have constipation and who have hard stool, and it is important to prescribe for 6 weeks until the complete effect of dietary management appears. Seeds bath, it aims to decrease pain, burning, and itching. It aids in hygiene and decrease the anal canal pressure. Soaking in warm water for a period of time, 10 up to 15 minutes, 2 or 3 times per day. Don't increase above this time, that it can cause skin maceration. Topical therapy, like topical ointment, suppository. It contains barrier protectant, other active ingredients like vasoconstricting agent, local anesthetic, anti-inflammatory agent. However, there is a little evidence to support the use of this agent. Oral therapy, including phlebotomics like Daflon. This increases the vascular tone, reduce venous capacity, decrease capillary permeability, increase lymphatic drainage, and have an anti-inflammatory effect. And usually it decreases the bleeding, pain, and itching sensation. Office-based treatment, This is for internal hemorrhoid. Why for internal hemorrhoids only? As internal hemorrhoids lack of somatic innervation, and this make this procedure available to be performed in outpatient clinic with no pain to the patient. And it is important usually to leave a distance above the dentate line, 1 to 2 centimeter. This procedure causing scarring, fibrosis, and finally fixation of the hemorrhoid high in the anal canal. There is no special preparation required. Usually the patient placed in left lateral position prior to the procedure endoscopy to determine the hemorrhoid need to be treated, and after the procedure the patient can resume normal diet and activity shortly after procedure. There is usually minimal discomfort after the treatment, and this is the technique of hemorrhoidal banding. Hemorrhoidal banding is the most common of these office procedure. This is the internal hemorrhoid, and we start with grasping the internal hemorrhoid, and this is a device which allow apply the band, and this is a rubber band. And here we finally deploy the rubber band on the internal hemorrhoid, and this is another method of office-based procedure, infrared photocoagulation, coagulation of the hemorrhoid, and this lead to ischemia. This injection sclerotherapy, injection of certain agent in the hemorrhoid itself, causing fibrotic reaction. And these are the surgical treatment of hemorrhoidal disease, divided into non-resectional procedure and resectional procedures. Non-resection like laser hemorrhoidoplasty, ligation-based techniques, and resectional stable hemorrhoidopexy, conventional hemorrhoidectomy. And the most performed and the gold standard is conventional hemorrhoidectomy. It remains the gold standard. Why? It is associated with minimal recurrence, fewer complications. However, it is associated with significant post-operative pain. Pre-operative enema, useful to evacuate the rectum. It may be performed under local anesthesia, plus sedation, or even under full general anesthesia. Positioning according to the preference of the surgeon may be modified lithotomy position or bronchial knife position. Excisional hemorrhoidectomy may be open technique, which is Milligan-Morgan technique, and this technique is popular in Egypt, in UK, and European country, and Fraxon technique, which is popular in the United States of America. And this is how we perform Milligan-Morgan excisional hemorrhoidectomy. This is the patient placed in modified lithotomy position, and this is the shape of hemorrhoid. We start with grasping the enoderm, then grasping the pedicle of the hemorrhoid, like this picture, and we start dissection from the enoderm, drawing a triangle, the base of the triangle at the enoderm, and the apex at the pedicle of the hemorrhoid. And this is the completion of dissection after reaching the apex of the hemorrhoidal pedicle, and this is the internal sphincter and external sphincter, and this is important to protect the sphincter. And this is another view of completion of the dissection. This is the enoderm where we started the dissection, and this is the mucosa, and here's the pedicle of the hemorrhoid. Now we will apply ligation of the pedicle and excision. And this is the final shape. And remember this shape. What is the importance of this shape? Leaving a bridge of skin and the mucosa between the excised hemorrhoid, and protection of the underlying sphincter here and here. Complication of hemorrhoidectomy. Urinary retention is a common complication, and to avoid this complication, restrict fluid intake during the procedure and proper pain control. Hemorrhage may be immediate as a result of technical error, may be late due to sepsis and sleep ligation. If you have a patient with bleeding after hemorrhoidectomy, immediate backing of the anal canal, or tamponade with a Foley catheter. If bleeding does not stop, take the patient to operative theater. Anal stenosis due to excessive endoderm removal, and this is why we stress on leaving a sufficient bridge of skin and mucosa between the excised hemorrhoid. Post-operative pain, post-operative infection, and common complication. Fecal incontinence may be due to the stretch of the anal sphincter during retraction, or direct injury to the sphincter, or loss of hemorrhoidal contribution incontinence. How to treat thrombosed external hemorrhoid? As we said before, this is a self-limiting condition. If the pain starts to subside, non-operative treatment will be a wise option. Non-operative treatment include sitz bath, laxative, analgesic, phlebotomics, and topical nitroglycerin. If the patient has intense pain and there is no improvement, excision. How we perform excision? This is a thrombus and this is the anal verge. We will make an incision over the thrombus. Dissection of the thrombus, removal and closure with absorbable sutures. Strangulated internal hemorrhoids. How to treat? The same concept as thrombosed external hemorrhoid. However, when non-operative treatment failed, urgent hemorrhoidectomy is indicated. And this is an example. This is stable hemorrhoidopexy. We don't need to know more information, just we use a circular stapler. And this is a non-resectional procedure, ligation-based technique. It uses Doppler-guided instrument, and by this Doppler-guided instrument, we localize the branches of the superior hemorrhoidal artery, and we do dearterialization, ligation of this branches. And this is the laser hemorrhoidoplasty. It is a device with a laser catheter, and we insert this laser catheter and cause denaturation of the protein of the hemorrhoid and it changes in size. And this is an example of non-resectional procedure. And finally, this is an important, very, very important algorithm for the treatment. And remember, take sufficient history from the patient, performing digital rectal examination, and based on history and examination, we will able to define those patients who need colonoscopy. And the treatment will be according to the type and the grade. If we have a patient with external hemorrhoid, surgery after failure of conservative treatment. And if we have a patient with internal hemorrhoid, we will start with conservative treatment. If it failed, for grade 1, grade 2, office-based procedure. For grade 2 or grade 3, ligation-based technique and laser hemorrhoidoplasty. For grade 3 and grade 4, resectional procedure. And these are our conclusions at the end of the lecture. Classification of hemorrhoidal disease based on the degree of clinical prolapse. Medical therapy should be the initial treatment recommendation for all patients. Office-based procedures offered for internal hemorrhoids only. Excisional hemorrhoidectomy is the gold standard treatment. However, post-operative bleeding may occur. Urgent hemorrhoidectomy reserved for strangulated and gangrenous hemorrhoids only. If you have any question, feel free to send this question to me, Mostafa Shalaby at mons.edu.eg. Good luck. Thank you.